honorable chairpersons and the Academic Ophthalmic Forum for giving me the opportunity. So my talk is on a novel ringless polyfocal intraocular lens which doesn't have any negative dysphotopsia, halos and glare, and with excellent depth of focus. So whenever we look for an ideal premium IOL, so what are the features we want? So number one is the no negative dysphotopsia, minimum positive dysphotopsia with no photic phenomena like the halos and glare, ability to correct distance intermediate as well as the near vision, as well as it needs to be cost effective too. So the answer to all of these problems is Autofocus Pro. That is a make in India, a ringless polyfocal progressive posterior chamber intraocular lens. It has been developed under the leadership of Dr. Jagdeep M. Kakadia, Dr. R.C. Shah, Dr. Satish Desai, Dr. Vikrant Bhale, and myself as an R&D director. So this is in the upper part, you can see this is the Autofocus Pro. It looks just like a monofocal, but it works like multifocal. So it is an aspheric polyfocal progressive lens, and it doesn't have any diffractive rings as seen in the below picture. It is static and fixed in the back, and there is no mechanical pseudo-accommodation. And as you see in the mesopic condition, when the pupil is fully dilated, in the other premium IOL with the 6 millimeter of the optic, there is this 10 to 20 degree of aphakic area. And this leads to negative as well as the positive dysphotopsia. So when we see it under the NITEC OPD scan, it just looks like a progressive glasses. So this is the design. So it is overall size is 13 millimeter with 2 holes. The serrated outer L-shaped, modified L-shaped, serrated haptic edges. It's moving on its own. So this is the design. And the haptic size is 7.5. So there is no aphakic area. And how it is able to correct the distance intermediate and near vision. So there is a patented GRIN technology, that is gradient refractive index. So in the superior part, the IOL needs to be dialed in the superior part with 2 holes in the upper direction. So in the superior part, the refractive index is 1.42, and it gradually increases to 1.54 in the inferior most part. And this is how it has the ability to correct distance intermediate as well as the near vision. As you can see, there are 2 holes, and so it corrects all 3 types of vision, even in 0.9 millimeter of the pupil. It is pupillary independent. And as we compare it with the other premium IOLs, so there is a modified C loop as seen in this picture. So only a few millimeter of that modified C loop, it touches the capsular fornix. But here in this IOL, the modified L-shaped with serrated outer zigzag edges like the feast knuckle. So it is the whole 6 millimeter is in the contact with the capsular fornix, and hence gives it an excellent rotational stability. These are the videos of this implantation. So it comes in preloaded version, 100% hydrophobic, as well as in the copolymer also, in which the 74% is hydrophobic and the 26% is hydrophilic. So easy loading, and it has both the options of the screw or the pusher. So both the options are there, and we don't need to push it the whole intraocular lens. We just need to push 50% of the IOL. Rest of the IOL, it opens very lazily on its own. So here you see, we need to just push it, just 50% of the intraocular lens, and rest of it, you can see, it opens on its own and gives ample time to maneuver it and push it into the back. And the angle kappa or the angle alpha, they are of no significance or importance. Even in the hyperopes with more than 0.7 millimeter, with power of 25, 27, we are implanting it. And these are insignificant because there is no loss of light energy, because there is no destructive interference or the diffraction. So these all 3 zones are present. And the excellent depth of focus, the only IOL with the depth of focus is from 3.5 to 5 diopter. So even if our biometric reading is wrong, it goes haywire in some of the condition, still the patient vision will be 6/6 part or 6/9. And it is a forgiving IOL for the post-operative refractive surprises because of the excellent depth of focus. No other IOL has this level of depth of focus. And even if our power calculation a little bit wrong, it doesn't matter. And we don't require the expensive optical biometers also, and we can have a good night's sleep. Contrast sensitivity is as good as any monofocal intraocular lens. Reading speed of more than 150 to 200 words per minute, and as there is no optical noise because the diffractive or the refractive rings are not there, even the posterior apodization is not required, so there is almost no neuroadaptation, and the patient instantly adapt to it, and it can be implanted in previous eye having a monofocal IOL or other premium IOL. So in more than 1.5 lakh implantation all over the globe and 15,000 by myself, not a single patient is complaining of any dysphotopsia. And because of the reason that there are no affected area when the pupil is fully dilated, 7 millimeter. So you see there is, we have explanted 18 patients with other premium IOL implantation complaining of nagging negative dysphotopsia, and the patients are very happy. And this large lens advantages, bigger YAG we can do. Even if the capsular axis is not perfect in size and shape, we can still go ahead and implant this IOL. And even if a large PC rent, we can still implant and capture. And the material is such that there is no pitting of the IOL, it is anti-glistening. Now coming to the modulation transfer function, that is a very important aspect of any premium IOL. So when we go for the multifocality, so it starts to decrease. In the monofocal, it is up to 80%. But when we go for the multifocality, it starts to decrease and it is 30 to 40% in most of the premium IOL. But this is the only IOL with more than 70% of the MTF value. It is the crisp and the clear quality of the image at the retina. So in conclusion, after 1.5 lakh implantation, there is no intraocular lens. It is the enhanced monofocal. It is the enhanced EDOF, and the toric version is also about to come. Within 3 months, it will be commercially available. So all the IOLs, they are gem, but the real crown is, of course, Autofocus Pro intraocular lens. Thank you so very much. And I am happy to take any questions.
Thank you, Arvind, for telling us about autofocus. A very elementary question, Arvind. Please don't mind my asking such an elementary question. So the zones in which the intermediate and the near vision is there, as I thought from your diagram, it is in the inferior part, is it not? The inferior part, the near vision and the intermediate vision, right? So my question would be that if it is a 2.5 millimeter pupil, so how does that get accessed by the near vision zone?
Yes, I shown one slide that if the pupil is only 0.9 millimeter dilated, the most myotic pupil, all the 3 zones are there. So that is not an issue. We are implanting it in the Urad-Zavalia syndrome because it is pupillary independent.
Arvind, actually, see, even with a 0.9 millimeter, how can all the 3 zones be present in a 0.9 millimeter?
That is a patented this green technology. So even the pupil is smaller, the smallest of the pupil, 0.9. We have done first the lab study. The study is published in PubMed. I can share it with you. So we had done all the inside lab first, all the investigations of the optical. So even in the 0.9, it is all the 3 zones are present there.
0.9, how, I mean, then what is the description of the zones? I mean, in millimeter, in terms of millimeter. Say in 0.9, if the distance, middle, intermediate, and the near is present.
There are no zones at all in this.
There is no zones.
No zone at all.
There is no zone.
You showed it in the slide.
No. There is no zones. It is polyfocal progressive. There are no refractive or diffractive zones. Not at all.
Okay.
Yeah.
So
we are only fiddling with the refractive index.
Okay.
Right. So this is a patent. So in the superior part is it 1.42. Gradually it increases to 1.54.
So it is it like the advanced monofocal designs?
It can be advanced extended depth of focus, we can say that.
What
It's
is-
just like LensTech ClearView 3. They have the slider, so we have added further into it. So this is better than in the optical quality we talk about. It is better than the LensTech ClearView 3.
Only thing is you need to place the lens horizontally.
Yes, of course. The
Yeah.
superior holes, they need to be dialed in the upper part.
Upper part.
Even if we go 35%, 35 degrees wrong, still the patient vision is good. If it is more than that, we need to again redial it.
There was a lens by name Oculentis. Still it's available, I'm not sure. That also is something like a D bifocal. The superior part is for this thing, then the inferior part it will have for intermediate and near vision. Oculentis. It was the UK based company. Subsequently, I think it was also marketed by Topcon, if I remember right.
Yes,
No
we are
doubt.
getting the material, the require to make this IOL, we are getting it from the same UK company.
Same company.
Yes,
Ah,
the material, only the material.
okay.
Okay, what is the longest follow-up that you have with these lenses?
Longest follow-up, it was approved by CDSU and DGHS in 2019. So now we have around 6 years, up to 6 years follow-up we have. Even in my mom's eye, I have implanted this IOL bilateral, and she is very happy. 3 months back only.
Okay.
Thank
3
you.
months follow-up in your
So
mom's eye.
publications, Arvind?
There are already 3 publications, and one is accepted in JCRS. So that is the next publication. It is head-to-head clinical trial with this ICRIL multifocal from Biotech.
Okay, thank you.
Thank
Your
you.
mom is not going to complain even if something goes wrong. So it's
She is my brand ambassador now.
Arvind, is mom happy with you first of all? Happy with the lens?
Moms are always happy with their sons, even if they are wrong.
that's why I said she's not going to complain even if something is
Thank
a
you.
mess.
Thank you so
Thank
very
you.
much.
Thank you very much, Arvind. We would like to have Professor Lahane, and from him, definitely we would learn